So let's start a new module here. We're going to talk about a number of different medications, including calcium channel blockers, which are used for hypertension and as well for as anti-anginal medications. We're going to discuss congestive heart failure and acute coronary syndrome, and also discuss medications that relate to them as well, such as ACE inhibitors and angiotensin receptor blockers. Okay, so let's get started. So this slide on cardiac rules, we've reviewed this before. Nothing new here at all. These are just general cardiac rules when you're dealing with antihypertensives, medications that can either drop blood pressure or reduce heart rate. And also we want to know weights, because often we're using diuretics for conditions such as heart failure or hypertension, and we would want to know if someone's gaining or losing significant amounts of weight. And of course, the orthostatic symptoms that we have to advise people on in terms of changing positions very slowly to avoid getting dizzy and potentially having a syncopal episode. Syncope meaning to have a brief loss of consciousness because the blood pressure dropped to the point where your brain wasn't perfused. Okay? And also the concept of not stopping cardiac or antihypertensive medications abruptly. Since you can have a rebound hypertension, you can have rebound of your anginal symptoms, such as chest pain, shortness of breath. So never a good thing to stop abruptly. So let's talk about calcium channel blockers. And in order to do so, let's talk about calcium channels first. So where are we going to find calcium channels? They are very populated on the vascular smooth muscles, so the arterioles in the blood vessels, in the systemic circulation. So calcium is involved in vasoconstriction. So assuming there's no calcium channel blocker around, calcium helps the smooth muscle of the arterioles vasoconstrict. And when you vasoconstrict, you get a higher blood pressure. Calcium channels are also in the heart, and they are involved in maintaining a certain heart rate and contractility of the heart. Okay? So now let's think about when we block some of these calcium channels. So if we block the calcium channels in the arterioles, in the systemic circulation, and when I say systemic circulation, when I'm talking about antihypertensives, it's usually the arterioles. So when we block them, the smooth muscle can't contract, it vasodilates, and you get a reduction in blood pressure. And so that's why they can be used as antihypertensives. Let's go to the heart now and see what they do there. So if we block the calcium channels in the heart, we can slow down the heart, because as mentioned before, calcium channels are involved in chronotropy, right? They're involved in the electrical conduction. So when we block them, we are slowing down electrical conduction. We are slowing down the heart rate. They are also heavily involved in contractility of the heart. So if we block the calcium channels in the heart, we can reduce contractility of the heart. Okay? And if we reduce contractility and heart rate, that will also drop your blood pressure because your cardiac output is being reduced. And also that is reducing the overall workload of the heart. The heart's not beating as fast and it's not contracting as hard. So if you are someone who has, say, hypertension, high blood pressure, and angina, calcium channel blockers can be very useful in both conditions. They can reduce your blood pressure and they reduce the workload of your heart, thereby improving your anginal symptoms. So when I say improving your anginal symptoms, that usually means less exertional chest pain, less shortness of breath, less need to take other medications such as your nitro pills when you get anginal symptoms. Okay, so we'll get into these a bit more. Some calcium channel blockers just block the calcium channels in the arterioles. They don't touch the heart. And some calcium channel blockers block the channels in the arterioles and the heart. Okay, so when we're thinking of calcium channel blockers, we always have to split them into two groups. The group that only causes vasodilation because it stops vascular smooth muscle contractions, and the group of calcium channel blockers that does both. It causes vasodilation by blocking those smooth muscle calcium channels, and also affects the heart by blocking the calcium channels and reducing contractility and heart rate. Okay, so again, good medications for hypertension, angina, and also for certain fast rhythms that we would really like to slow down. Okay, so let's now split them into two groups. So there's calcium channel blockers that only vasodilate the arterioles. They don't do anything to the heart, and those are called dihydropyridine calcium channel blockers. And there's two very common ones in this group. There's other ones. These are by far the most common. Nifedipine and amlodipine. Just vasodilate. And the non-dihydropyridine calcium channel blockers. And these vasodilate, just like the other ones, but they also slow down the heart and reduce contractility, reduce inotropy. Okay, and we'll talk about the differences coming up in another slide. Okay, so let's talk about nifedipine a bit. The brand name is Adalat. And again, I mentioned that there's two very common ones in this group, nifedipine and amlodipine. And these are dihydropyridine calcium channel blockers. They have very, very little effect on the heart. They don't slow it down. They don't reduce contractility. They really have their effect on the vascular smooth muscle calcium channels. And when they block them, they cause vasodilation, relaxation of the smooth muscle of the arterioles, causes vasodilation and a drop in blood pressure. So these are medications that we can definitely use for hypertension. Okay, we can also use them for angina, because by reducing blood pressure, it reduces the afterload on the heart, makes it easier for the left ventricle to pump blood out into the aorta, less work. As well, they do cause vasodilation of the coronary arteries. which is very nice, because if you do have some angina, which is usually from blocked coronary arteries, then some vasodilation of the coronary arteries will also reduce angina. Okay, these medications can be used for hypertensive emergencies, where some of them can be used IV to reduce severe hypertension. And as well, calcium channel blockers as a group can be used for daily dosing to try and prevent migraine headaches. So if someone has recurrent severe migraine headaches, they can be offered a daily dose to try and prevent them from coming on. And it makes sense, right? I mean, these medications work on the blood vessels. We suspect that migraine headaches are a blood vessel vasoconstriction and vasodilation problem. So by controlling that with these medications, they benefit people with migraine headaches. Just like beta blockers are used, such as propranolol is used for migraine headaches, right? So those are the indications. Now, the actions we spoke about, vasodilation of vascular smooth muscle and the coronary arteries. Okay, so peripheral arterioles and the coronary arteries. And just remember what angina is. Angina is when your heart is working, but there's not enough oxygen supply through the coronary arteries. Okay, so it's a supply and demand problem. So angina is increased work of the heart with the same supply of oxygen through the bloodstream that goes through the coronary vessels. So for example, if you have a blockage of some of your coronary arteries, which is common in someone with angina, and then they go to run or they start walking up a hill, well, the workload on the heart has increased, but they really can't get enough blood by the occlusions, the blockages that are in the coronary arteries, and that leads to a mismatch of oxygen supply and oxygen demand, and you get chest pain, shortness of breath, sweaty, all those symptoms of angina until you finally stop what you're doing, whether it's running or going up a hill. The workload goes back down to normal, and the oxygen supply equals the demand, and the chest pain goes away. Okay, so remember what angina is. Adverse effects. Well, we can work through all of these. Constipation, there's lots of calcium channels in the gastrointestinal tract. And if you block them, you're going to get constipated. Remember, you need calcium channels for smooth muscle contraction. So if you block them in the gastrointestinal tract, you're not going to get lots of contractions. You're going to get constipated. First dose phenomenon we've spoken about with any antihypertensive. You could get hypotensive with these because they vasodilate. Dizziness comes from hypotension. Headaches because the small arterioles in your brain are vasodilating. So you can get these pounding headaches. Reflex tachycardia. Well, if you've vasodilated the arterioles, which is how they work, the heart is going to say, well, I'm just going to speed up because I notice my blood pressure is going down. So initially, in the first couple of days, you'll get a reflex tachycardia from these medications. Okay? Now, you could put someone into heart failure by making their heart beat a bit faster temporarily, that reflex tachycardia. But that would have to be someone who has pretty severe heart failure to begin with, if you're tipping them over into more heart failure. Flushing of the skin, well, you're getting vasodilation of the blood vessels in the skin, and you get flushing. Swollen, puffy legs is totally due again to the vasodilation of those arterioles. So people often come back a week later and say, I have a bit of edema or swelling in my feet now, or my ankles. And that's often from calcium channel blockers. Okay, so in terms of contraindications, just a bit careful in the elderly with this group, because remember, this causes only vasodilation. So when they get up too quickly, they can have a syncopal event where they faint temporarily and fall. Okay. Avoiding with alcohol, I guess everything in moderation. I don't think there's an absolute contraindication to alcohol. I think it's more until you're on the medication and you're stable on it. Monitoring vital signs for sure. Cardiac rules, very important. Lifestyle changes in terms of whether you're trying to control the hypertension or the angina. So definitely telling people to lose weight, to control diabetes, to stop smoking, to go for regular exercise. Those are all really important things to keep on reminding people. Calcium channel blockers interact with grapefruit juice. So the interaction can elevate the calcium channel blockers. And I think that's probably enough on these. In general, these are very well tolerated medications. They're used very often in hypertension and angina. Okay, so let's look at the other group. And the other group is the non-dihydropyridine group. And this group consists of two main medications, verapamil and diltiazem. And remember, they have the smooth muscle vasodilation of the first group of calcium channel blockers, such as amlodipine and nifedipine, but they also have the heart rate lowering effects and the reduced contractility of this group. So we can take advantage of that in terms of treating very fast heart rates, such as a condition called atrial fibrillation, which is just a fast atrial rate. And we can control that with one of these, whether it's verapamil or diltiazem. We can slow down the fast heart rate. And there's other fast heart rates that we can definitely control with one of these because of their effects on the heart. We can also use it for angina, right? In fact, these are more effective for angina than the first group. And I'll tell you why. Not only do they cause vasodilation, like the other group, and that reduces afterload, they also slow down the heart and they reduce contractility. So less work load of the heart, less cardiac demand of oxygen, less angina, right? And they also are very effective for hypertension by vasodilating and slowing down the heart and contractility at the same time. So this non-dihydropyridine group blocks the calcium flow in the vascular smooth muscle, in the cardiac cells, which leads to peripheral vasodilation, decreased contractility, and decreased heart rate. Right? So they're negative chronotropes negative inotropes, unlike the other group. Now let's look at the side effects. Well, they're going to be really similar, right? Isn't that nice? They're going to be similar but not identical, because this group works on the heart as well. But constipation, for sure. Flushed skin, headaches, dizziness, lightheaded, some peripheral swelling because it vasodilates. So you might have some puffy ankles. You'll have the flushing. You could get hypotensive on these. We could make your heart failure significantly worse. These are negative inotropic drugs, meaning they're going to reduce contractility of the heart. And if your contractility is already reduced because of heart failure, it will be aggravated by these drugs. We could make you bradycardic because they slow down the heart rate. And as mentioned, increased congestive heart failure symptoms such as shortness of breath with lying at bedtime, which is called PND, paroxysmal nocturnal dyspnea. That's a weird word. But basically what it means is when I lie down at night, I get these episodes of severe shortness of breath. And that's usually an indication of congestive heart failure. Okay. What about the contraindications? Well, anything where the heart's already slow, you wouldn't use these. So an AV, a heart block. So AV is atrioventricular heart block, but let's just say heart block in general, where you already have a slow heart rate. This will definitely aggravate that. If someone's already hypotensive, if someone's already bradycardic, these would not be good drugs to administer to those patients. Okay. So nursing responsibilities, the vital signs are really important in terms of heart rate and blood pressure, cardiac rules, lifestyle considerations. You should avoid grapefruit juice with this group. So, in summary, for this group, very effective for high blood pressure, hypertension, very effective for angina, and effective for tachydysrhythmias or tachyarrhythmias, fast heart rates that need controlling. And the most common that we'll mention is atrial fibrillation, that the heart rate needs to be slowed down. So we'll talk about this later, but in actual fact, calcium channel blockers are in a group of medications also called antiarrhythmics, since some of them are able to slow down or alter the rhythm of the heart. They're antiarrhythmics, just like beta blockers are also in a group that we'll talk about later called antiarrhythmics, because they can alter the rhythm of the heart. Okay? So I know they're also antihypertensive and anti-anginals, and you'll start to see that one drug can be in multiple groups. So one drug can be an antiarrhythmic if we're looking at this slide. That same drug could be an anti-anginal. Same drug could be an antihypertensive. So they have different indications and they fall into different groups. Okay, so let's talk about the next topic here, the renin-angiotensin-aldosterone system. So if you haven't come across this before, it can seem a bit overwhelming, but it doesn't need to be. Okay, so let's just go through this. So this system is a system in the body, and the main reason for this system is to make sure that blood pressure is at a good level, is high enough to make sure that the brain is perfused with blood. Okay? So if that's the case, then this is a good system to address if we want to lower blood pressure, such as in hypertension. All right, so this system was discovered. We realized that it's involved in maintaining blood pressure. So in patients with high blood pressure, we have found drugs to block this system at various sites, so that it has less of an effect on blood pressure and thereby reduces the blood pressure. Okay, so let's start near the top. So renin is produced in the kidney, and it is secreted in the kidney when it detects low blood pressure. Okay, so the body does not like low blood pressure. It has multiple systems that are activated in low blood pressure. Think about that, because I'm going to mention them in a minute. So there's multiple systems that turn on when your blood pressure is low. And this is definitely one of them. Okay, so renin is secreted with low blood pressure, reduced perfusion to the kidneys. And it goes into the bloodstream and it converts angiotensinogen that's produced in the liver, like most proteins in the body, and it converts it to angiotensin 1. Now it's in the bloodstream. Angiotensin 1 is in the bloodstream, and it is converted to angiotensin 2 by angiotensin converting enzyme. So ACE, angiotensin converting enzyme, that is often found in the blood vessels in the lungs, in the respiratory system. So it's felt that angiotensin 1 is converted to angiotensin 2, mainly in the blood vessels of the lungs. Okay, so now you have angiotensin 2. We haven't spoken about drugs yet at all. We're just talking about how this renin has activated this whole system to try and raise blood pressure. So now look at angiotensin 2, which again is still just a protein. It was angiotensin 1, and it's been converted to angiotensin 2 by an ACE enzyme. And now the effects of angiotensin 2. So the first one is it goes to the pituitary gland, or the pituitary gland, and stimulates ADH secretion. Okay, well, that's interesting why I would do that. It also goes to the adrenal gland and stimulates aldosterone secretion. It goes to the blood vessels, the arterioles in your body, and it's a very powerful vasoconstrictor. So that's going to immediately increase your blood pressure. Okay. It is also involved in cardiac remodeling, meaning angiotensin 2 is going to be involved in increasing the work of the heart to maintain blood pressure. Okay, so now let's go back to all these effects. So ADH secretion. Well, if angiotensin 2 causes ADH secretion, well, ADH is now in the bloodstream. It's going to reabsorb even more fluid, because that's what it does. And that's going to increase your blood pressure. And that was the initial intention of this entire pathway. Aldosterone that's been secreted by angiotensin 2 is going to go to the kidneys, reabsorb sodium, reabsorb water, increase blood pressure. Perfect. That's what it wanted to do. The vasoconstriction we spoke about. And the cardiac remodeling of angiotensin 2 has to do with increased afterload. So because you're constantly vasoconstricting the arterioles, you can get cardiac remodeling. You can get thickening of the muscle in the heart. So the chambers are getting thicker, the muscles are getting thicker. So these are the effects, and the whole idea of this pathway is to increase blood pressure. Okay, so what are the systems that are turned on when your blood pressure drops suddenly? So you're in a car accident, your blood pressure drops suddenly. Okay, so your blood pressure is now 70 systolic. Your sympathetic system turns on. And your sympathetic system is a system that is activated, and it releases epinephrine and norepinephrine, and it powerfully vasoconstricts the blood vessels and causes the heart to beat fast and hard, everything to maintain blood pressure. The low blood pressure will now activate this system to maintain blood pressure. Low blood pressure also activates ADH secretion. So not only does the renin-angiotensin system activate ADH secretion, but even low blood pressure itself activates ADH secretion to reabsorb as much fluid from the kidneys as possible to maintain blood pressure. Okay, so you have the sympathetic system, you have the renin-angiotensin-aldosterone system, and you have the ADH system all turning on to say, do everything you can to maintain blood pressure, because that's what the brain will need to survive. So the net effect of this system when it detects low blood pressure is to elevate blood pressure, right? So now we can look at different sections of this pathway, and there's been drugs that have been invented to block the system so that you don't get all that angiotensin 2 stimulation causing elevated blood pressure. Okay, so there's angiotensin converting enzyme inhibitors, there's angiotensin 2 receptor blockers. If you look at aldosterone, there's a drug called spironolactone that blocks aldosterone. There's a renin inhibitor right at the top of this pathway that inhibits renin from acting right at the beginning. So companies have looked very hard at this pathway, and they've tried to find a number of different medications to block this pathway so that angiotensin 2 doesn't have all of these effects that it does. And the final effect of angiotensin 2 is to increase blood pressure and increase blood volume. That's the final effect of what angiotensin 2 does. So there's many drugs that can block part of this pathway. I hope that makes sense. Okay, so let's start with a drug called captopril. And there's quite a few ACE inhibitors. This is an ACE inhibitor, so an angiotensin converting enzyme inhibitor. And because this group is a popular group to prescribe for a number of conditions, there's many drugs in this group. And notice that they all end in pril. Okay? So this blocks angiotensin 1 from becoming angiotensin 2. So that's what this drug is blocking the enzyme that typically does that. And by doing that, if you go to the slide above, you'll see that it blocks a number of things. Because if you're reducing production of angiotensin II, you're also reducing aldosterone secretion from the adrenal gland. You're reducing ADH secretion from the pituitary. You're stopping cardiac remodeling. You're reducing hypertension by allowing some vasodilation, since angiotensin II is a powerful vasoconstrictor. So this drug is very popular for hypertension. It's also very popular for heart failure. It reduces blood pressure, and it also reduces cardiac remodeling, which is detrimental in heart failure in the long run. So by stopping angiotensin II from constantly remodeling the heart, making the ventricular muscle, the myocardium, thicker, it is beneficial for patients in heart failure. Okay, it's also beneficial for patients after a heart attack, because cardiac remodeling happens there as well. So this medication inhibits cardiac remodeling after a heart attack. And it's also been shown in diabetic nephropathy, where diabetics are now leaking protein or albumin into their urine because the nephrons are becoming very leaky, that ACE inhibitors are beneficial to slow down the progression of the diabetic nephropathy. So that's another indication. So the action we already discussed, that it inhibits the ACE enzyme, leading to decreased angiotensin II production. So in terms of adverse effects, because ACE inhibitors block the ACE enzyme, there's a certain chemical or a molecule that's increased as a byproduct called bradykinin. Okay, and bradykinin, it was noticed actually that increased levels of bradykinin and the use of these medications actually caused a chronic irritating cough in people. So someone would start an ACE inhibitor and they would have a persistent cough and tickle in the back of their throat. And after studying it for a long time, it was discovered that bradykinin was really the cause of this. These drugs can also cause angioedema, which is very specific. There's very few drugs that directly cause angioedema, but this is one of them, where you can get tongue swelling, lip swelling, airway edema. This is not anaphylaxis. This is just an effect of the drug. So people can be on this drug for any length of time and develop angioedema. It can happen at the beginning, or it can happen years later of having been on this drug. So those two, the cough secondary to bradykinin, very common, and now angioedema is an important side effect. And let's go to another important side effect, hyperkalemia. So because this group of medications inhibits aldosterone secretion, it can lead it stops reabsorption of sodium and water in the nephron, but at the same time it blocks secretion of potassium. So ACE inhibitors can cause hyperkalemia. Okay, so that is another important side effect of ACE inhibitors. Now, can they cause hypotension if given in higher doses? Sure. There is also a black box warning for ACE inhibitors and also ARBs that are coming up in the discussion on the next slide for fetal injury and death during pregnancy. So ACE inhibitors and ARBs are not used during pregnancy. So let's just go over those adverse effects again. So the increased byproduct of this drug in the body is a chemical called bradykinin that can cause this nagging, tickling cough to patients that will persist. The only treatment really is to take them off the ACE inhibitor. It's just going to keep on, they're going to keep on coughing. And two other very important side effects, hyperkalemia and angioedema. Okay, so those are the main adverse effects. The contraindications, you'll see a history of hyperkalemia. So if you have severe renal failure, or if you're on dialysis and you're prone to hyperkalemia, that would be a reason to avoid ACE inhibitors. Or if you've had a history of angioedema previously on these drugs, you definitely would not take them again. Okay. In terms of the nursing responsibilities, for sure, vital signs, since this will drop your blood pressure. It won't usually have a big bearing on heart rate. Cardiac rules, those are for any cardiac or antihypertensive. Always reminding people of lifestyle changes and what a big effect they can have. Monitoring potassium level and monitoring kidney function labs, such as creatinine, very important. And remember that they end in PRIL, PRIL. That's the group for ACE inhibitors, okay? Because we will go on to another group called angiotensin receptor blockers, ARBs, and they will have their own ending, okay? Okay, so just a summary to get this into your understanding. Very good for hypertension. Why? It blocks production. It reduces production of angiotensin II. Okay. Good for heart failure. It blocks angiotensin II, which is going to reduce blood pressure, but it also blocks the cardiac remodeling that occurs with this RAS system, okay, and that's beneficial in the long run. For myocardial infarction patients, someone who's had a heart attack, so post myocardial infarction, these are beneficial drugs to again reduce blood pressure and reduce cardiac remodeling, and of course for diabetic nephropathy to reduce the progression of renal failure. Okay, so now let's just look at the angiotensin II receptor blockers. So if you need to go back to that slide with the information of where, like just that map that we spoke about earlier on in this module, to see where these drugs are blocking. So they're blocking angiotensin II from having all of its effect because they are blocking the receptors. So losartan, very common one. Valsartan, very common. I think remembering the last part is what's most important because you recognize that this is an ARB. And basically, it's going to have very similar indications to the ACE inhibitors. It's blocking the same pathway, just a bit further down. It's going to have similar effects. So hypertension, sure, it blocks angiotensin II from having its effect, and also reduces aldosterone. Heart failure, sure, it blocks angiotensin II from having its effect and blocks aldosterone secretion. thereby stopping reabsorption of fluid and sodium. Patients with high risk of cardiovascular events, diabetic nephropathy, and reduced mortality after an MI. So these drugs are also used after a myocardial infarction. So by far the most common, hypertension and heart failure. And also someone who has diabetic nephropathy. So kidney disease, leaking protein into their urine from diabetes. Okay. Action blocks receptors, which causes inhibition of angiotensin II from binding to the receptor and having its ability to act in the body. It's still going to have that adverse effect of hyperkalemia because you blocked aldosterone from being secreted by the adrenal gland. So hyperkalemia is still there, but notice there's no cough, and it's not there because you didn't produce those bradykinins that are involved with the chronic cough of ACE inhibitors. Sorry, my mind went blank there for a minute. Dizziness, well, that's just from potentially low blood pressure. Fatigue, that could be from low blood pressure too. The angioedema is still there. Okay, there's still a possibility of causing angioedema with ACE inhibitors. Okay, so what has disappeared? ACE inhibitors versus ARBs is the chronic cough. Okay, still has that black box warning for fetal injury and death during pregnancy. So what are the contraindications? Well, definitely someone who has severe renal injury or severe kidney failure, they're prone to high potassium. ARBs put you at risk for higher potassium. We avoid them. Hyperkalemia already. So what about someone on dialysis that's prone to getting high potassium before they go for their next dialysis treatment? We're not going to put them on an ARB or an ACE. We could put them into a deadly cardiac arrhythmia from hyperkalemia. Okay. If you've had a history of angioedema from ARBs or from ACEs, we wouldn't use any of them in this group. Okay. Someone who has a cough, by the way, on an ACE can still safely use an ARB. Okay, so if you come back after taking your Captopril for 2 weeks and say, I got this nagging cough, it won't go away. Okay, we can switch you to an ARB, and we'll wait for your cough to go away, which can take weeks and weeks. Okay. So nursing responsibility, definitely monitoring vital signs. They're often on it for blood pressure anyways, so we want to see that it's controlling the blood pressure. Just following those cardiac rules, not giving it if the blood pressure's too low, or if the heart rate's too low, or if they have orthostatic symptoms, to advise them on it. And of course, lifestyle changes. They still need renal checks, like creatinine checks and electrolyte checks, to make sure that they're not hyperkalemic. Okay, so let's talk about angina and myocardial infarction. Okay, so there's a lot of information on both of these topics, and of course there's many different drugs. So let's just try and get a framework where we can then understand the medications and what they do and what they're supposed to do. Okay, so angina, as we mentioned before, is typically from an occlusion of a coronary artery. So atherosclerosis is a condition where you begin forming plaques in different arterial beds or arteries in your body. So you can have peripheral vascular disease where you have atherosclerosis forming in the arteries to your legs, for example. You can have atherosclerosis to the arteries to your brain, leading to potential TIAs and strokes. And you can have atherosclerosis to the coronary arteries, and we call them plaques. So plaque formation gradually progresses over time. The plaques gradually occlude the coronary artery over a long period of time, unless the plaque ruptures suddenly. So if it's a plaque that's just gradually taking up more and more space in the artery, in the coronary artery, that's a very gradual process. And when you reach a certain percentage of blockage of the coronary artery, you start to get angina. So say it's 60 or 70% blocked, because that's typically what it takes for the blood to be reduced and for you to start to get symptoms. So very small degrees of blockage, such as 20 or 30%, are nothing. They don't typically cause anginal symptoms. So as we get towards 60 to 70% blockage of a coronary artery, the patient develops symptoms of angina when they exert themselves. So the blood supply has to still get to the heart, and under resting conditions, there's enough blood supply and oxygenation to meet the demands of the myocardium, of the heart muscle. But when you exert yourself, or when you climb up a set of stairs or climb up a hill, you are increasing your workload of the heart, which is then requiring more blood flow from the coronary arteries to feed the myocardium with oxygen. And of course, sugar. So if there's a mismatch during exertion, that you cannot supply it enough blood through the coronary arteries due to an occlusion, then you develop anginal symptoms. And when you stop and rest, and the heart begins to slow down and stop contracting as hard, the anginal symptoms gradually go away. Okay? Now, this is on a spectrum, right? So you can have very mild angina at very high exertional levels, or you can have severe angina, meaning that the plaque has progressed to say 80 or 90% and really limiting your activity before chest pain or shortness of breath begins. So you can have mild to severe angina. If the plaque or the atherosclerotic plaque ruptures suddenly, so instead of progressing very gradually over years, it suddenly ruptures. Well, you don't have stable angina anymore. That was very predictable. That when you went up a flight of stairs, you got chest pain. Or when you walked up a certain hill, you got chest pain. That was stable chronic angina. With plaque rupture, the inside of the plaque is now ruptured out, and the fatty tissue is now exposed to the blood that's in the coronary artery, and a thrombus forms because the artery recognizes this ruptured plaque as foreign, and it tries to clot it off. So you get a thrombin clot on top of the ruptured plaque. So ruptured plaque, well, first the platelets adhere to it, and then thrombin adheres to it, and you get a complete occlusion of the coronary artery, and that leads to a myocardial infarction, a heart attack. Now, say that the ruptured plaque occurs, but it doesn't completely occlude the coronary artery. Well, we call that unstable angina, meaning you're getting chest pain at rest, you're getting chest pain with exertion, you're getting unpredictable episodes of chest pain and shortness of breath and sweating. That's plaque rupture. It just hasn't gotten to the point of completely blocking the coronary artery and leading to a heart attack. But it's almost there. Okay, so you have this spectrum of stable angina to unstable angina, meaning plaque rupture but not complete occlusion of the coronary artery. And then if that were to completely occlude the coronary artery with the ruptured plaque, the platelets on top, and then the thrombin clot all happening at the same site, if it completely occludes, then you have a heart attack. Okay, so we're going to talk about different drugs that we use for angina and for myocardial infarction. And let's just look at the groups here a bit in this slide. So what drugs would we want to, what do we want to do with these drugs with angina is to reduce the workload of the heart so that the coronary arteries that have an occlusion, have a fixed occlusion, say it's 50% occluded or 60%, the heart's never going to beat that fast or contract that hard with certain drugs. So the drugs are going to reduce the workload of the heart. Okay, so they haven't changed anything necessarily with the blood supply in terms of the plaque that's in the artery, in the coronary artery, but we've reduced the workload of the heart so that it's not demanding as much blood flow. Okay, and beta blockers do this. So they reduce heart rate and they reduce myocardial contractility. And by doing that, so heart rate and contractility, they're going to start to reduce cardiac output and the workload of the heart, so they won't require as much oxygen. Okay, so they work on the sympathetic system and block it. So even though the occlusion is still there with stable angina, the heart isn't working as hard because of the beta blockers reducing heart rate and reducing contractility. Okay, what about calcium channel blockers? Well, they dilate the smooth muscle in arterioles in the systemic circulation, so in the arteries. So they're going to reduce the afterload, the amount of work that your heart has to pump against, which is your blood pressure. They're going to reduce blood pressure, your afterload, and that'll reduce workload. And some beta blockers that we just discovered not long ago also reduce the heart rate and reduce contractility of the heart, and that will reduce workload. Okay. The other thing that calcium channel blockers can do is that they can vasodilate the coronary arteries a bit themselves. Okay, so that will increase the blood flow a bit to the heart. So it will increase supply, while the drug is also reducing the oxygen demand of the heart by all those effects we just mentioned. Okay. And lastly, the group here is nitrates. So nitroglycerin, and this comes in a variety of ways to administer it. It comes in a sublingual pill. It comes as a sublingual spray. It comes as a patch. It comes IV. It comes orally. And it's all about doing the same thing. So nitrates, what do? They vasodilate, in particular the veins. Okay, so that's going to reduce the amount of blood coming back to the heart, which will reduce preload. And when you reduce preload, the heart isn't having to pump as much blood to the lungs, and also the return of the blood from the lungs to the left side of the heart is reduced, so the left side doesn't have to pump as much blood into the aorta. So you're reducing preload, and that reduces the work of the heart. Okay. Now, of course, nitrates, by reducing preload, will also reduce your blood pressure, because if there's less blood returning to the heart, there's less blood leaving the heart, and that's going to reduce systemic blood pressure. And they also dilate coronary arteries. So by dilating the coronary arteries, you're increasing the blood supply to the myocardium. So not only have you reduced the blood returning to the chambers of the heart, so decreased workload of the heart, you've also increased the supply of blood that feeds the heart in the coronary arteries. So another way, so these are the groups that we just that we will end up talking about. We've spoken about calcium channel blockers. We've spoken a bit about beta blockers. We'll talk about some nitrates soon. So let's just think of this from another point of view. Say I inject someone with epinephrine or norepinephrine. Well, that's a sympathetic stimulator. What's that going to do to someone who has angina already? Well, it's going to make their heart beat faster and harder, and it's going to make them prone to an anginal episode, right? Because I've just increased the workload of their heart with a fixed amount of oxygen supply due to the blocked coronary artery. Okay, so whenever we're giving epinephrine or any kind of sympathomimetic, such as nasal decongestants, or anything that speeds up the heart, like an anticholinergic drug, someone who has angina, we can make it a bit worse because we're either speeding up the heart or making it work harder. And if they already have angina, they can have more anginal symptoms by medications that we've given them. Okay. And then, of course, any of these medications that we're looking at here, beta blockers, calcium channel blockers, and nitrates, will reduce anginal symptoms because of how they work. Okay. And remember, stable angina is just a plaque that's blocking more blood supply down the coronary artery, compared to unstable angina or a heart attack, which is under the umbrella of acute coronary syndrome, ACS. That is plaque rupture and a thrombus formation at the plaque. So that's a critical blockage of the coronary artery, or a complete blockage. So unstable angina is typically a critical blockage, but not totally blocked. And a myocardial infarction is typically a complete occlusion. Okay. And so symptoms of angina will be whenever the heart is working harder. So it'll be exertional chest pain or exertional chest fullness. People often use pressure and fullness and pain interchangeably. Symptoms of shortness of breath. It can radiate, the pain or the discomfort can radiate to the neck, to the jaw, the shoulder, or the back. And often in women, they can present with very different symptoms, which can be even more difficult to initially diagnose: angina or a heart attack. Okay. Sometimes epigastric pain, which is upper abdominal pain, can be from angina or a heart attack. Okay, so look at the three groups and try to understand how they reduce angina. And we'll also talk to them in terms of why we use them after a heart attack. But certainly, the nitrate group, reducing preload, dilating the coronary arteries, well, that makes sense. The beta block group, reducing contractility, reducing heart rate. That makes sense. It's going to reduce the workload of the heart, which will control angina. And then the calcium channel blocker group. Okay. Okay, so this slide is showing a patient holding his left arm, and then some images of the heart and coronary vessels. So, I think this image is to discuss myocardial infarction, a heart attack. And really there's two types of heart attacks, and this won't be the only slide that I'll mention this, but heart attacks are I mean, sure, there's different locations for heart attacks, but underlying the condition of heart attack, we break them into two types. One's called a STEMI, an ST elevation myocardial infarction. So there's a segment on the ECG called the ST segment. And when it's elevated, which it is in the setting of an ST elevation MI, then we call it a STEMI. If someone's having a heart attack and their ST segment isn't elevated, then they're having a non-ST elevation MI. So those are the two large groups that we break heart attacks into: STEMI and non-STEMI, irrespective of the location that the heart attack is in. Okay? And an NSTEMI usually means that there's a very, very tight blockage. So the ruptured plaque has occurred, the platelet aggregation, the fibrin, the thrombus has formed, but there's still a bit of blood flow going through, a tiny bit. And they're not getting a full thickness from one side of the muscle to the other side, a full thickness myocardial infarction that you would get in a STEMI. They get a partial thickness in a non-STEMI. Okay, so a STEMI is what's called a transmural infarction, meaning it's a full thickness heart attack, and an NSTEMI is a partial thickness heart attack. Both of them have positive troponins in the bloodstream. So either heart attack, because there's been muscle death, right? So a heart attack is myocardial infarction. Infarction means cell death. So in either one, there's been cell death. When you have cell death, you release, well, at least in the heart, you release troponin. So both are positive for troponin. So really, it's based on the ECG at the beginning, whether it's an ST elevation or a non-ST elevation. Okay, so what this is showing is there's an occlusion in an artery, and if it's an ST elevation MI, we can use a thrombolytic. Now, it's not usually with a catheter that goes into the coronary artery. It's usually just intravenous thrombolytic therapy through a peripheral IV. Okay, and what the thrombolytic tries to do is to break up the fibrin clot or the thrombus at the ruptured plaque site and restore some circulation so that the myocardium can receive blood supply and oxygen again. And if it's successful, then you will reduce the size of the heart attack with a thrombolytic. All right. So thrombolytics are very effective drugs. They're very, very powerful blood thinners. So there's a questionnaire that we go through very, very quickly prior to giving thrombolytics. Do you have any bleeding disorder? Have you had a recent stroke? Have you had recent surgery? Have you had any bleeding from your gastrointestinal tract? Does the patient have uncontrolled hypertension in the emergency room? Anything that could lead them to bleed elsewhere. Because if you bleed while you're on a thrombolytic, it's often deadly, especially if the bleed occurs in your brain. For example, you have a hemorrhagic stroke because you had severe hypertension and you were given a thrombolytic. Okay, so very effective to try and open up an occluded coronary artery. So in terms of timing, sure, we can give thrombolytics up to 12 hours, but remember, the earlier the better. The term is time is muscle. At 12 hours, there's been a lot of damage and a lot of infarction already, so the thrombolytic won't be that effective. So the sooner it's given for a heart attack, the better the outcome will be if it opens the coronary artery. Okay. And I think that's it for this slide. So we'll go into the different types of heart attacks on another slide. Okay, so this next slide is talking about nitroglycerin formulations. So there's many different ways of giving nitroglycerin for angina or control of angina or treatment of someone who comes in with ischemic chest pain. So we'll go through, I'll tell you which ones are important, which ones really we don't use much anymore. So sublingual tablets. So this is given for so people carry around these in their pocket, and these are taken for an anginal episode. So someone has gone up a flight of stairs, they have a history of stable angina, and now they have chest heaviness and shortness of breath. Okay, so luckily at the top of the stairs there's a bench they can sit on, and they take out their nitro tablets and they put one under their tongue. And they can do this two more times, so three in total, over a span of 15 minutes. Okay. If the person is unresponsive to nitroglycerin after having taken the tablets, that's an issue. They need to contact emergency services. Usually stable angina is very responsive to sitting down, resting, and taking sublingual nitroglycerin. Okay. So that's used for an anginal episode. The next one I'm not going to spend too much time on because we really don't use them, the buccal tablets. Even the next one, the sustained release tablets or capsules. So these were a bit difficult to take. You had to take them before a meal or 2 hours after a meal. They were often 3 or 4 times a day. So it made it very difficult for people to take them. They do still exist, oral nitroglycerin for controlling chronic angina, chronic stable angina. So you always have a bit of nitro in your bloodstream during the day. The next one, translingual spray, is basically the same as sublingual tablet, except it's in a spray form. And it's very popular in many countries, including Canada, where we really don't use the tablets anymore. We use the spray. And you spray it under your tongue. You can repeat it every 5 minutes, up to a maximum of 3. And you treat it basically as a sublingual tablet, but it's a spray. The next one is transdermal ointments, where typically the nurse would measure out. It's almost like you had a tube of toothpaste and you were just measuring out 2 or 3 inches of a strip of nitrile ointment, and then we would apply it to the person's arm and tape it there. This is not used very much anymore. It was a bit inaccurate. It was often an estimate by the nurse on how much to put on, and it was greasy. The patch would slide out of place, and so not used very often anymore. And this was really replaced by the transdermal unit. So this is a transdermal nitrile patch that you can apply every day, again to control anginal symptoms. And you put it on a non-hairy and a non-rash part of the body that doesn't involve excessive movements or use. So, you know, your upper chest, your outer arm, and you rotate it every day. Now, you typically leave it on for 12 hours. So say 8 in the morning until 8 at night. You need a 10 to 12 hour nitro-free period of time for any nitrile product. Nitroglycerin has to be out of your bloodstream for a period of time for it to continue to be effective. So you can't take round-the-clock nitroglycerin for angina. So typically the patch, in this case, is removed at 8 o'clock at night, and a new one is applied the next day to another part of the body. And this patch, this transdermal patch, continuously releases nitroglycerin through the day, which can be very effective to control a patient's anginal symptoms. They can still take a sublingual tablet if needed, if they go up that flight of stairs and they get chest pain. But this is in addition to other medication, this transdermal patch to control the symptoms of angina. And lastly, intravenous nitroglycerin. This is usually used in an emergency setting, and it's usually used in someone with unstable angina that is resistant to other treatments that we've tried, such as sublingual nitroglycerin, aspirin, oxygen, maybe a beta blocker, other medications, and we can't seem to control their ischemic chest pain. And we don't just want to cover it up with morphine or fentanyl. We want to control the ischemic chest pain by relieving the ischemia. So intravenous nitroglycerin is started, and it's slowly titrated up. So the dose, so this is usually very, very close monitoring, and the drug is titrated up gradually. And really what we're watching for is hypotension. So as long as the blood pressure remains within acceptable limits, we can continue to increase the nitroglycerin IV drip to try and control a patient's ischemic chest pain. If hypotension develops, then we'll have to back off or reduce the nitroglycerin intravenously because of the common side effect of hypotension. Remember, nitroglycerin causes vasodilation, so it will definitely drop your blood pressure as the dose gets higher and higher. Okay, so the nurse is very careful watching as he or she titrates the medication, the IV nitroglycerin, up for hypotension, and also watches very closely for control of ischemic chest pain symptoms. And once the chest pain resolves, the nitroglycerin dose can remain at that current level and not continue to increase. Okay, so let's talk about acute coronary syndrome. And remember, acute coronary syndrome was this umbrella term for unstable angina. So the plaque has ruptured within the coronary artery. There's almost complete occlusion, and there's thrombosis on top of it. There's a thrombus on top of or with the ruptured plaque, but it hasn't completely occluded, and there's been no heart attack. So there's been no release of troponin. And then an NSTEMI, a non-ST elevation MI, is a heart attack. So there's been an infarction, a myocardial infarction. It's not a full thickness one, it's a partial thickness. And there's been no ST elevation on the ECG. Okay, so these heart attacks are usually, so they're partial thickness, and they're usually what are called subendocardial. So the muscle just above where the chamber of a heart would be, not a full thickness infarction. And then a STEMI, an ST elevation MI, is a full thickness MI. It's from a complete occlusion of the coronary artery, and it has resulted in a transmural infarction, right? Full thickness. And you see ST elevation on the ECG. Okay, so what do we want to do very quickly when someone presents with ischemic sounding cardiac chest pain? So someone comes to the triage, it really sounds like they're having ischemic chest pain. And when we say ischemic chest pain, we mean chest pain that really sounds like it's coming from the heart. So they're short of breath, they've got crushing chest pain, they're sweaty, they have radiation to their shoulder or their arm, and they look pale. So we bring them right back. We wouldn't do the vital signs in triage anymore. We would just bring the patient right back. So what do we want to do quickly? Well, for sure we want to get an ECG. We need to distinguish what this is, right? Is it a normal ECG? Is it an ECG that's showing some signs that are concerning for a STEMI? Or are there just some minor changes on the ECG that are suspicious for an NSTEMI? Okay, so really we need an ECG. We need vital signs, including an O2 saturation. We need IV access, okay, because we're likely going to be giving medications. By the way, this is all happening at the same time. Okay, it's not one after the next, It's all happening at the same time. So the targeted history, meaning what, please tell me what your symptoms are today. We might get a bit of a brief family history, a brief past medical history of the patient, what medications they're on, a very targeted physical exam. If we see a STEMI on the ECG, then we will do, depending on which hospital you're in. If you're in a large hospital, they're going to go right to the cath lab, because a STEMI needs immediate attention, and there's two options. You can go to the cath lab. That's catheterization lab, where they put a catheter in an artery of your wrist or your groin, and they feed it up to your coronary arteries, and they spray dye into the coronary arteries. That's called an angiogram. The angiogram shows which coronary artery is blocked, and they can try and put a catheter through the blocked coronary artery and open up the blockage, the ruptured plaque, and that's called angioplasty. So You put the catheter through, you blow up a balloon at that area that's blocked. It pushes everything against the wall of the coronary artery, and then after that you can have a stent can be inserted to hold everything open. So that's only for a STEMI and in a large hospital where you can have very quick access to the cath lab. In a rural setting where it may take hours to get to the cath lab, a fibrinolytic can be used. And a fibrinolytic or a thrombolytic is the same term, same drugs, okay? So we need to go through a very quick checklist to make sure that someone doesn't have any contraindications to using the fibrinolytic. And those contraindications invariably are any kind of bleeding issue, whether it's a recent stroke, a recent gastrointestinal bleed, whichever. Anything to do with bleeding is often a contraindication, or severe hypertension that can put you at risk for bleeding after receiving a fibrinolytic. Okay. We also obtain blood work, so we get routine blood work, but really the one we're looking for is troponin. And troponin will help distinguish whether this has been a heart attack or this is unstable angina. Now, when someone first comes in, and if we see a STEMI on the ECG, then we're not waiting for the troponin, because sometimes the troponin will come back negative early on in the course of the disease. Just hasn't had time to rise in the bloodstream. So the troponin levels are very useful to help distinguish between a heart attack, whether it's an NSTEMI or a STEMI, and a non-heart attack, such as unstable angina. Okay? But just remember, if we see a STEMI on ECG, we'll act on that without the troponin levels. And also trying to obtain a portable chest x-ray is useful. It's not urgent, but we'll try to get one in the first 30 minutes so that we can have a look at the lungs and make sure the lungs are fully inflated, and other things as well. Okay, so what else are we doing with someone who's come in with suspected ACS, acute coronary syndrome? As a reminder, that consists of unstable angina, meaning ischemic chest pain, likely some abnormalities on ECG, negative troponin, or an NSTEMI. Likely some abnormalities on ECG, not ST elevation, and a positive troponin. Or, of course, a STEMI, which we've already discussed, either goes directly to the cath lab or gets a fibrinolytic. So if their oxygen is low, and low meaning less than 90%, they will receive oxygen, and typically starting at 3 or 4 liters per minute, and gradually increasing so that we're happy with their O2 saturation. And usually we like to see an O2 saturation of greater than 95 or 96%. So if someone comes in with an oxygen saturation of 98% and they're having chest pain, they don't usually need oxygen. Their O2 saturation is 98%. So bringing out the oxygen isn't really going to be beneficial to them. Giving aspirin very quickly. So we give aspirin, 2 baby aspirins, which is 160, 81 milligrams each, so 162. And usually it's been given by the ambulance, but if it hasn't, or we're not sure it has, we give it again. So if the patient comes from home and says, I'm pretty sure I took aspirin, we're not really sure, we'll give it again. And that's because aspirin can be so effective because it's an antiplatelet medication, and it stops platelets from continuing to adhere to the ruptured plaque in the coronary artery. Nitroglycerin sublingual tablets or spray can be used to try and help the ischemic chest pain that the patient is experiencing. And lastly, IV morphine can be used for discomfort. But remember, IV morphine is really just covering the chest pain. It's not treating the underlying problem, which is lack of oxygen to the myocardium, which is happening with a ruptured plaque. So once we've addressed all the other things that we'll get into, whether it's blood thinners, nitroglycerin, oxygen, all the other things that we'll get into, then if it still persists and we're happy with all the other treatments we've given and we want to start some IV morphine, then that's totally fine. But remember, we don't want to cover the pain until with an analgesic such as morphine, unless we've really addressed all the underlying or addressed all the potential treatments to stop the ischemic chest pain from happening. Okay, so let's talk about nitroglycerin. And remember, nitroglycerin comes in a variety of formulations, right? So you have the tablets that go under your tongue when you have an anginal episode. So that's just an as needed for angina. And you can take up to 3 of those in the span of 15 minutes. And if you're having to take the 3rd nitro pill, and you're sitting down, you've taken 2, and you're heading towards your 3rd nitro pill, and you're not having resolution of your chest pain, then you should really consider calling 911 or heading towards your local hospital. So nitroglycerin is a powerful arterial and venous vasodilator. Okay, so if you can imagine it causing so much vasodilation that it's going to reduce the blood returning to the heart, and it's going to reduce the afterload, your blood pressure, which is afterload. It's going to reduce arterial blood pressure. Okay, so it's definitely going to reduce the workload of the heart. There's less blood coming back, so there's less to pump from the right side of the heart to the lungs. And there's less to pump from the left side of the heart to the aorta, to the systemic circulation, because you've reduced preload and afterload. Okay, so it's going to reduce oxygen demand from the heart because it doesn't have to work as hard. So for an acute anginal episode, that's perfect. You've just climbed up 3 flights of stairs. You have some chest pain, shortness of breath. You sit down. You take a nitro tablet under your tongue, and you wait for it to have its effect, which is reduction and resolution of the chest pain or chest heaviness. Right? Heart failure and acute pulmonary edema. We'll do that. We'll do those together. So if your left ventricle is not able to pump very forcefully, you have a weakening left ventricle. Blood is going to back up into the lungs, and that's called pulmonary edema. So how can we fix that? Well, why don't we try and make it easier for the left ventricle to pump forward into the aorta by dropping the blood pressure. So nitroglycerin will definitely drop your blood pressure and help the blood pump out of the left ventricle instead of backing up into the lungs. But it's also going to do something else. It's going to reduce the blood returning to the heart that wants to be pumped to the right, to the lungs, from the right ventricle. So it's doing 2 things that's really helping heart failure. Less blood going to the lungs, and more forward flow of blood from the left ventricle because you've dropped systolic blood pressure. So very good for heart failure with pulmonary edema. In acute MI or unstable angina, like we spoke about before, someone who has unremitting ischemic chest pain that just won't settle, we will try to give them intravenous nitroglycerin to settle their ischemic chest pain by taking as much work off the heart as possible. Okay, and we can use nitroglycerin for severe hypertensive episodes or hypertensive emergency, and often this is used in an IV setting, and we'll just titrate the nitroglycerin up until the blood pressure drops to a level that we like, and then we can keep the nitroglycerin stable at that level. Okay. And lastly, it's not mentioned here, but just someone who has stable angina that needs to use a nitro patch every day. They put the nitro patch on in the morning, they remove the nitro patch at 8 o'clock at night until the next day, and then they apply another one. And that's to prevent inginal episodes. So that's a very common reason for using nitroglycerin, is prevention of inginal episodes. Okay. So the adverse effects, they're all going to be, well, most of them are going to be from the fact that nitroglycerin vasodilates your blood vessels. So headache, you can get a pounding, severe headaches because the nitroglycerin has vasodilated the blood vessels in your brain. Pounding headaches. Drop in blood pressure, orthostatic blood pressure, again because you vasodilated all of your blood vessels. Flushing, which is vasodilation of the skin blood vessels. Dizziness and lightheadedness related to lowering of blood pressure. And you can get a tolerance to nitroglycerin. So that's why you need that 10 to 12 hour period of nitro-free in the bloodstream. So you can use nitro for 12 hours. So the nitro patch usually you'll apply in the morning and remove in the evening. And then no nitroglycerin as a patch or as regular dosed pills until the next day. Now, if you wake up in the middle of the night because you have chest pain, can you use your nitro tablets under your tongue? Absolutely. But it's more to have that nitro-free period of around 10 to 12 hours. Contraindications, so hypotension, it'll make it much worse. I wouldn't use it. Shock, it'll make it much worse. Elevated intracranial pressure, well, because it vasodilates the blood vessels in the brain, it'll make that worse too. Okay. Now, in terms of nursing responsibilities, for sure, vital signs, especially if someone is starting on some kind of nitro formulation, even a sublingual tablet for an inginal episode can drop someone's blood pressure. So it's always nice to know at the beginning, like, how is this nitro tablet under your tongue going to affect your blood pressure? For many people it doesn't. For almost everyone, nitroglycerin gives a pounding headache though. Showing administration techniques, especially something like a transdermal patch that you're going to be using every day to apply it to a clean area of skin, not hairy, no rashes, and the area needs to be rotated, right? Otherwise you tend to get a rash from the adhesive over time. And I think that's it for this slide. Okay, so I'm just going to leave you with one analogy. I like analogies because sometimes it helps understand a process. So let's just say you have a pump and there's water from a hose coming into the pump. That'll be your venous system. And then there's a hose leaving the pump under pressure, under much higher pressure, and that'll be your arterial system. So the pump accepts blood to return to it, the venous system. It pressurizes it, and sends it back out under much higher pressure. Okay, so let's say that that pump is weakening, or the electricity which powers the pump is weakening. So what can we do? We can improve the electricity to the pump, and let's just say that's your coronary artery, that's your blood supply, your energy supply to it. So nitroglycerin vasodilates the coronary arteries, which is basically the same as saying I'm improving the flow of oxygen to the heart. Just like in the pump analogy, I'm improving the electricity flow to the pump so it works better. All right. What about the pipe coming into the heart? Well, that's your venous side. Nitroglycerin vasodilates the venous system, so less blood is rushing back to the heart. Well, that's good. In this pump analogy, if less fluid is coming to the pump, it allows the pump to rest a bit, so it doesn't have to continually pump all this fluid that's coming into it. Let's go to the arterial side, or the high pressure side of the pump analogy. There's vasodilation there, so less blood pressure and less pressure that the pump has to exert to get the blood moving forward. So it'll make pumping of the heart, or this pump, much easier to get the blood moving forward. So nitroglycerin helps out in many, many ways to reduce the workload of the pump, i.e. the heart, and to improve some oxygen supply by vasodilating the coronary arteries. So hopefully that analogy helps a bit. If not, just ignore it. Okay, so this is a slide that we purposely left on Mona, because it used to be a very common mnemonic to remind you of the medications that you need to give a patient. And Mona stood for morphine, metoprolol's been added there, oxygen, nitroglycerin, and aspirin. And really, this thinking has changed. It's not really the case anymore at all. So, when someone comes in with ischemic chest pain, what we want to do is get their vital signs and check their oxygen. And if their oxygen is low, we're definitely going to apply either nasal prongs or a facial or a mask to provide oxygen to the patient. Okay. So oxygen should really be at the top. And then aspirin is extremely important for ischemic, a new onset of ischemic chest pain. It's an antiplatelet. It tries to stop the platelet from clotting up the coronary artery even faster. So aspirin should be near the top as well. Nitroglycerin, as we just spoke about, takes the workload off the heart. So in someone with ischemic chest pain, that may reduce the ischemia. So far we have oxygen, and then aspirin, and then nitroglycerin, and lastly, morphine. Because all morphine is really doing is covering the pain. Okay? It's not doing anything else. And years ago, that was okay. Treat the pain first. But you're really not treating the pain with morphine. You're just covering the pain, because really the pain is coming from the fact that the heart is not receiving enough oxygen because of a blocked coronary artery. And if we address the fact that the heart is starving of oxygen, then the pain will go away. So really, we don't try to cover it with morphine as much anymore. So the order now, and often these things are done all at the same time, but the order would be more oxygen, aspirin, nitro, and then morphine. And then sometimes we'll use metoprolol later on to slow down the heart and reduce contractility so that the heart's not working as hard. So I hope that makes sense. Okay, so let's talk about some medication management for the spectrum of diseases that we've been talking about here. So we've been talking a bit about stable angina. We've been talking a bit about someone who now has plaque rupture, where you can now have unstable angina, that unpredictable chest pain, the pain that's coming much more frequently. It's coming at rest. That's unstable angina. No heart attack yet. And then next down the spectrum is an NSTEMI. So a heart attack with positive troponins, maybe some ECG changes, and then a STEMI, which positive troponins and ST elevations seen on the ECG. Okay, so we use a lot of different types of blood thinners in depending on which condition we're talking about that I just listed. So anticoagulants, those would be drugs such as warfarin, low molecular weight heparins, and they're used as blood thinners for more of the acute coronary syndrome. So if someone comes in with unstable angina or an NSTEMI, we will use heparins or low molecular weight heparins to make sure that their blood is remaining thin so that flow continues in the coronary artery and not more clotting occurs. We also use antiplatelets for that as well, such as aspirin or clopidogrel. Aspirin or clopidogrel is also used on a daily basis for people with coronary artery disease to prevent clotting in the coronary arteries. So even someone with stable angina is taking a daily dose of aspirin. And if aspirin wasn't effective and they had another cardiac event, they may now be on lifetime of clopidogrel. Thrombolytics are really only used for STEMIs, so ST elevation MI, okay? And that's typically in the setting where you can't access a cath lab, such as a rural hospital, or a hospital that's far enough away that you can't get to a cath lab in that 2-hour window, and we use thrombolytics for that. So that's really the one place for the thrombolytics. So blood thinners, what are the advantage of them? Well, they try to maintain some blood flow and stop clotting that's occurring in the coronary artery under different circumstances, whether it's stable angina, unstable angina, an NSTEMI. In NSTEMI, sometimes we'll use aspirin, clopidogrel, and a heparin to try and treat it. And as I mentioned, thrombolytics for a STEMI. Angiotensin converting enzymes, and this would also go for angiotensin receptor blockers. So think of those as the same group. They're used for blood pressure control. They're used to stop that cardiac remodeling that occurs over time. They're used in heart failure. Again, that cardiac remodeling that is detrimental to the heart over years. So we use these often. Beta blockers, beta adrenergic antagonists. We use those for blood pressure. We use those to reduce the workload of the heart by decreasing chronotropy and decreasing inotropy. Calcium channel blockers, we use them because some of them, such as verapamil and diltiazem, also slow down the heart rate and slow down and reduce contractility. And we use them for blood pressure because they vasodilate the periphery. Nitrates we've mentioned, we use it for angina, anginal episodes. We use them to control angina over the long term with regular use of pills, but more often now in transdermal patches. We can use the nitrates for unstable angina or an NSTEMI where the chest pain isn't going away. We'll give them intravenous nitroglycerins. Pain management definitely has a role where all these other medications have been used and tried and the patient is still suffering with pain. We will definitely use some intravenous morphine or intravenous fentanyl, which is another opioid. And sometimes when the heart is failing, congestive heart failure, we may use a vasopressor to bring the blood pressure up. Okay, so vasopressors vasoconstrict by alpha-1 stimulation. Inotropes increase contractility of the heart by beta-1 stimulation. So an example of a vasopressor would be norepinephrine. An example of an inotrope would be dopamine. Okay? So these are just to get an idea of the different medications that are used. Okay, so therapeutic lifestyles. I think we've gone over this before, but again, these are things that can have a huge impact. Really controlling blood pressure, whether that's through medications, diet, weight loss, whichever ones. All blood pressure control is really important. Maintaining optimal weight. So, I mean, the heavier someone is, the more the heart typically has to pump and work harder. And increased weight often leads to hypertension and diabetes. Okay. Implementing an exercise plan is always a good idea. Monitoring blood lipid levels, cholesterol, the LDL, HDL, triglycerides. Okay, so there's evidence that reducing LDL and increasing HDL is beneficial to reduce atherosclerosis in all of the arteries of your body, but also in the coronary arteries, since we're talking about the heart. Reducing dietary salt intake, reducing saturated fats, that's animal fat, and reducing dietary cholesterol, which typically comes with saturated fats. Increasing soluble fiber in the diet. So oat bran, vegetables, roughage, beans will increase soluble fiber. That tends to keep some cholesterol in the gastrointestinal tract. It also avoids constipation, which is nice. Elimination of tobacco is huge. Okay, that is a real toxin to the cardiovascular system and accelerates atherosclerosis. Alcohol, so high levels of alcohol is cardiotoxic. So I know we think of alcohol as being toxic to the liver and causing hepatitis and also pancreatitis, but it's also toxic to the heart. Recreational drug use, so cocaine. So cocaine is a sympathomimetic. It's going to make your heart beat really fast. It's going to raise your blood pressure to tremendous levels and put you at risk for a heart attack or a stroke. So remember all these therapeutic, these lifestyle changes. They make a big difference if people are able to implement some of them. It's very hard to have an individual patient implement all of them. It's happened very, very rarely in the past 20 to 25 years that I've been working, but some will definitely be implemented, especially if you persist. Okay, so let's look at the beta blocker group. And the prototype on this slide is atenolol. So there's many beta blockers. And in general, as a group, they have very similar effects. There's slight differences between them, which we're not going to go into. We're going to go into the major differences. The good news is they all end in olol, which is important to remember. Remembering the endings of groups is always helpful to then remember the action and the indications of that group. So let's look at the indications of beta blockers, and remember the division of beta blockers: beta 1 selective or cardioselective, and non-selective beta blockers, right? And the division there has to do with the fact that non-selective beta blockers can impact someone's breathing a bit. If you're an asthmatic, or you have COPD, or you have pulmonary fibrosis, so we would lean more towards a beta 1 selective, as opposed to messing with beta 2 receptors in the lung. Okay, so let's look at some indications in general for beta blockers. Hypertension, well, because they reduce heart rate and reduce contractility, they can help reduce blood pressure in people with hypertension, so it can be very effective there. Angina, the same idea. By reducing heart rate and reducing contractility, the beta blockers are reducing the oxygen demand that's required for the heart to work. So it can reduce the symptoms of angina, such as the chest pain of angina or the chest pressure with activity, because there's less workload, right? So in angina, you have a partially blocked coronary artery that can supply a fixed amount of blood. So if you reduce the workload of the heart, meaning the demand of the heart, then you'll have less symptoms. In heart failure, so this one gets a bit confusing sometimes. In severe heart failure, what's happening is the left ventricle typically is failing, and the sympathetic system is forcing it to pump harder and faster to maintain blood pressure, right? So that's detrimental, because the heart is saying, I can't beat as hard as you want me to. I can't beat as fast as you're asking me to. And finally, the heart will fail completely. So beta blockers are used in severe heart failure to try and block the sympathetic nervous system from overstimulating the heart and forcing it to pump harder and harder and faster. Okay, so that's the idea of beta blockers in heart failure. After a heart attack, you want to rest the heart. And that's exactly what beta blockers do. They reduce heart rate, they reduce contractility, so they rest the heart. And also they drop blood pressure, which will also rest the heart, since it doesn't have to pump against high pressures. Okay, so the actions. So remember, selective, that's going to work on the heart. Beta 1 selective. And non-selective, well, it's going to have an effect on the heart, just like the beta ones, but it's also going to have an impact on the lungs by potentially making an asthmatic or a COPD or a short of breath. Decreased contractility, that goes for all of them. Decreased heart rate, that would go for all of them. And decreased conduction, electrical conduction, and that would go for all beta blockers. Adverse effects. Sure, there can be some nausea and vomiting. You can get dizziness, and dizziness would be a symptom of either lower blood pressure or potentially your heart rate's become too low and you're getting dizzy because now it's impacting your cardiac output and your blood pressure. Fatigue is a big one. Remember, just think of these drugs as slowing down the heart, slowing down contractions, slowing down heart rate, but they have a general overall fatigue. Patients will come back 2 weeks later and say, I can't take this drug. I feel so tired all the time. And sometimes it goes away and other times it doesn't. So fatigue is a big side effect with these drugs. Bradycardia, definitely a side effect. And always tapering these drugs slowly. If someone stops them suddenly, they're going to get a rebound tachycardia, potentially rebound of their angina, rebound hypertension. So tapering is really important with these drugs. Contraindications, well, if you already have bradycardia or some kind of a heart block or hypotension, we definitely wouldn't add a beta blocker. And the nursing responsibilities will come down to vital signs, tapering these medications if the intention is to get someone off them, and to follow cardiac rules. So remember, the main indications for beta blockers are really to lower blood pressure in patients with hypertension, to control long-term angina. Like, these medications will be taken every day to try and prevent anginal episodes. Someone could have a transdermal patch of nitroglycerin added to this. They may still have nitroglycerin sublingual tablets in their pocket. So beta blockers are one of many other drugs that can be used to control hypertension or angina, or for that matter, heart failure. In heart failure, the ventricle is weak, the pumping of blood forward, so it's typically your left ventricle, the pumping of blood forward is reduced cardiac output. So how do we want to help that? Well, we want to first try and reduce afterload, which is your blood pressure, and we can use that with an assortment of medications that lower your blood pressure. We want to try and remove some of the fluid off your lungs. We would use that. We would use a diuretic for that, such as furosemide. We might use a beta blocker to try and stop the sympathetic system from forcing the heart to beat so hard and fast. And we might use an ACE inhibitor or an ARB to not only reduce blood pressure, but to reduce all the cardiac remodeling that is occurring that's detrimental in the long term. So lots of these drugs are mixed together. Okay, so on this slide, ATI chapter 22, angina. So we've definitely already spoken about angina in heart attacks. And I find if you talk about the pathophysiology before getting into drugs, it's always helpful. If you get straight into the drugs and the pathophysiology isn't there yet, the drugs are very confusing, right? Like, well, what does this do? Preload and afterload and contractility, and so let's just spend a bit of time here. If this is repetitive, just skip it. Okay. So basically, we're going to be talking about the process of atherosclerosis, right? So atherosclerosis is where you get plaque buildup in your arteries, and the plaques gradually progress over time. Now, we know that there's risk factors that accelerate plaque formation, such as smoking, hypercholesterolemia, sedentary lifestyle, diabetes. So there's a number, hypertension. There's a number of risk factors. Some of them are reversible, some of them are irreversible. They're fixed, right? So being male is a risk factor. Well, before menopause, anyways, in females, they tend to get cardiovascular disease sooner. So under the age of 50 is a higher risk. Genetics, family history, that is irreversible. It's fixed. It's not a modifiable risk factor. Okay. So you get plaque formations in the upper part of this slide. And let's say this is a coronary artery. It could be an artery to your brain, could be an artery to your leg. But if the plaque is small, it's really not going to have much of a problem with flow of blood. Okay. As the plaque progresses and it gets towards 60 or 70% occlusion of the lumen, so the inside of the blood vessel, you can start to get symptoms. And typically with angina, which is atherosclerosis and plaque buildup in the coronary arteries, as it approaches 60 or 70%, you start to get chest pain, chest pressure, and it's typically exertional. So when you go to exert yourself, the heart works harder, the oxygen supply and the blood supply is fixed, and you get ischemic chest pain, right? So those are still stable plaques. They haven't broken open. They're just gradually progressing over years to decades. And that's what gives you stable angina, right? So people that have stable angina can predictably tell you how far it takes them to walk before they get chest pain, how many stairs it takes them to go up before they get chest pain. So it's very predictable. Now, if that plaque, let's still keep on the middle slide because I don't have a good third part here. I don't want to go right to heart attack yet. If that plaque were to rupture, so imagine that the angina slide there, if that plaque were to rupture, it would become unstable angina. That plaque has suddenly opened up and cracked open, and platelets are sticking to it. The coagulation system is now forming a thrombin clot on it, and the lumen of the blood vessel is now closing. So now you're running into trouble with unstable angina, rest pain, rest chest pain, increased frequency of chest pain, unpredictable chest pain. That's unstable angina, okay? No heart attack yet, no elevation of troponin, but that is the next step after someone with just stable chronic angina. So this is a complication of that, and it's because the plaque ruptured. Now, if the plaque ruptures and it leads to a severe occlusion or total occlusion, now we're looking at a heart attack. And that's the bottom one, right? So there's plaque rupture, platelet adhesion, thrombin clot, and now you either you get a heart attack, which is a myocardial infarction. And that's in two varieties, an NSTEMI or a STEMI. And the treatments are different. A STEMI, you get a fibrinolytic immediately, or you go to the cath lab. An NSTEMI, we're going to put you on blood thinners, maybe some beta blockers to rest the heart. So when I say blood thinners, an antiplatelet and an anticoagulant often is used. So often we'll use clopidogrel or aspirin as the antiplatelet, and a low molecular weight heparin, such as enoxaparin, or a heparin drip. So an NSTEMI treatment is different than a STEMI treatment at the beginning. They both have positive troponins. There's been a heart attack, so there's been release of troponin into the bloodstream, right? So know the term ischemia, which is the cells are being starved of oxygen, but they're not dead yet, and infarction, which means, yes, the cells have died, and in the case of the heart, we call it a heart attack, okay? Okay, so this next drug, definitely not a common drug, ranolazine. And I think if you recognize the name, there's not even many in this group. This is it, right? So if you recognize the name and what it's for, I think you're doing well. So the indication, so this drug is used for someone with stable angina that hasn't responded to typical other pharmacological treatments. So aspirin, beta blockers, maybe an ACE inhibitor, nitroglycerin, usually in the form of a transdermal patch, calcium channel blockers. So there's a whole list of medications that we would have gone through before turning to this medication, which probably tells you something about this medication, that it's not overly effective, right? So what's the action? Lowers cardiac oxygen demand, reduced contractility. Many of the drugs that I just mentioned before this one does that. The beta blockers, the calcium channel blockers. So this is not a common drug. Okay, so I'm not going to go through the adverse effects and the contraindications. I think if you know, this is kind of a last-ditch effort for stable angina. We've gone through so many other medications. And I'm going to tell you, if someone with stable angina is having ongoing chest pain and ongoing symptoms, despite all the medical treatment they're receiving, then they're likely going to go and have an angiogram, which is that dye test where they put a catheter into the radial artery in your wrist or the femoral artery in your groin, and they take the catheter and they put it all the way up to the proximal aorta, and they put dye in the coronary arteries, and we look for where the occlusion and blockages are to see if anything is can be reversed with angioplasty and a stent. So that would have been done in a patient with angina that's not responsive to most medications. Okay, so know the name, know what it's indicated for. So let's talk about heart failure now, and that's what this slide is on. So let's use an example. So say we have a 70-year-old patient who unfortunately had a heart attack, and part of their heart is now permanently damaged. They had a myocardial infarction. Okay, and their ventricle doesn't pump as well anymore because it is permanently damaged. Their left ventricle is weaker from the heart attack they had. So because of the reduced contractility from the heart attack, and by the way, this is the most common way that people get congestive heart failure, is a previous heart attack. So because of their weakened ventricular pumping, they're unable to maintain cardiac output into the arterial system. And the arterial system senses that. So your sympathetic system senses a slightly reduced blood pressure. Your renin-angiotensin system will sense reduced perfusion to the kidneys, and they're going to be activated. And why are they going to be activated? Because their primary goal is to maintain blood pressure. And there's really only two ways to maintain blood pressure. You can either cause vasoconstriction of the arterioles so that blood stays in the arterial side and your blood pressure stays up. That's one way. Or you can force the heart to contract harder and faster to increase cardiac output. And that's the second way to maintain blood pressure. And you know, from the brain's point of view, that is the most important, because the brain needs blood for oxygen and sugar and glucose to stay alive. So blood pressure is critical to the brain. But if you can imagine that the heart, because it's in a weakened state after the heart attack, it's now going to be stimulated by the sympathetic system to work harder, and it's going to also be stimulated by the renin-angiotensin system to pump against a higher blood pressure, because that's what angiotensin 2 is going to do. And there's also going to be remodeling of the heart, a thickened myocardium, cardiac, a heart enlargement, cardiomyopathy, or cardiac hypertrophy, an enlarged heart. So these mechanisms, the sympathetic system and the renin-angiotensin-aldosterone system, make a lot of sense in the short term to maintain blood pressure. But over the long term, they are causing detrimental effects to the heart, because they care so much about maintaining blood pressure and cardiac output that the heart, over time, over years, is having to work much more to maintain that, when really it can't, because it was damaged from the initial heart attack. Okay, so if you look at this slide, that's exactly what it's saying. On the right hand side, it's showing you the kidney and how there's going to be hypoperfusion to the kidney, which is going to release renin, which is then going to activate this whole cascade leading to angiotensin 2 production, which is then going to vasoconstrict, increase blood pressure. That's not great for the heart. Activate aldosterone to reabsorb water and sodium. That's more volume for the heart. That's not great. It's going to cause some cardiac remodeling, some cardiac hypertrophy, enlargement of the heart. That's not great. And then on the other side, you're going to have the sympathetic system that's making the heart beat faster and harder. And that's not great over time either. So that's why many drugs have been looked at that address these two systems, to stop the long-term effects of the sympathetic system and the RAS system, forcing the heart to beat harder and have a higher workload, which will then cause more heart failure. Okay, so so this slide is showing you different groups of medications that are used or potentially used in congestive heart failure. Okay, so remember, congestive heart failure is a weakened heart. It's typically reduced contractility of the left ventricle, And then, of course, fluid backs up into the left atrium, into the pulmonary vessels, leading to pulmonary edema. And then finally, it'll back up to the right side of the heart, causing right-sided heart failure. So the most common cause of right-sided heart failure is left-sided heart failure. So when we say congestive heart failure, most of the time we're referring to the fact that this person has left ventricular heart failure, unless we specifically say this person has right-sided heart failure. Okay, so when you have left-sided heart failure, left ventricular heart failure, you have decreased cardiac output, and you have backup of fluid. So we want to help that process out a bit by taking some of the stress off the heart. And here's the groups that will help. So the vasodilator group. So that's going to reduce the blood pressure, which is also called afterload. And a number of medications can be used for that. So we can use alpha-1 antagonists. And if you look at that there's an alpha-1 there coming from the sympathetic neuron. So alpha-1 antagonists such as terazosin or prazosin, they'll help vasodilate the arterioles. We could use nitroglycerin to vasodilate the arterioles and the veins for that matter. We can use hydralazine to vasodilate. So anything that vasodilates will reduce the blood pressure, which is reducing the afterload. That's going to help with the left ventricle being able to pump blood out of the left ventricle into the aorta. Okay, how about ACE inhibitors and ARBs? Well, they will either reduce angiotensin II production, ACE inhibitors, or block angiotensin II effects, ARBs. So that's going to cause some vasodilation of the arterioles because you've blocked angiotensin II. It's also blocked aldosterone from being secreted. So that is going to have a diuretic effect because sodium and water aren't being reabsorbed, so a reduced plasma volume. So that's going to help with congestive heart failure, reduction of blood pressure, and reduction of circulating blood volume. And also the ACE inhibitors and the ARBs stop the cardiac remodeling that's happening, the cardiac hypertrophy, the thickening of the myocardium, the enlargement of the heart. So they also help with that. Diuretics. Well, diuretics will reduce overall circulating blood volume, which is going to help with congestive heart failure, right? And by far the most common medication in that group is furosemide. What about cardiac glycosides? Well, the only one in that group that you'll need to know about and that we're going to talk about a bit later is digoxin. And digoxin is definitely not used as much any longer. The idea behind digoxin is that it's a positive inotrope. It helps contractility of the heart. And that's why it was used a lot with people in congestive heart failure. And the next group as well, phosphodiesterase inhibitors. It's a long name. There's going to be typically one in that group that you'll need to know about. And it's an IV drug, so people aren't going to be walking around the streets with this drug. It's called milrinone. And again, it increases contractility of the heart to try and help the left ventricle to pump blood forward into the systemic circulation. And lastly, the beta blockers. So what do they do? Well, in severe heart failure, they stop the sympathetic system, which is turned on because the sympathetic system is detecting that there's reduced cardiac output. They stop the sympathetic system from forcing the heart to beat harder and faster. And that, in effect, rests the heart. It allows the heart not to go further and further into congestive heart failure until it finally stops, because the sympathetic system is constantly trying to stimulate it. So beta blockers are used in severe congestive heart failure. So these are the different groups that we use to try and address congestive heart failure. And any one of these, they're often used in combination, these drugs. Okay, so so quickly let's go through these and give an example of each. We'll go counterclockwise this time. Beta blockers, atenolol or metoprolol. Cardiac glycoside, there's only one, thank goodness, digoxin. Phosphodiesterase inhibitor, that's in really severe end-stage heart failure because it's an IV drug, milrinone. It increases contractility. Okay, let's go down to diuretics. Furosemide or butanamide. Those are loop diuretics. They drain fluid out of the circulating plasma volume. ACE inhibitors, captopril, ramipril, very common. ARBs, by far the most common, losartan. Or anything ending in a sartan, but losartan is very common. Reduces blood pressure, reduces cardiac remodeling, reduces aldosterone secretion from the adrenal gland. Vasodilators, alpha-1 antagonists like prazosin, terazosin, nitroglycerin in a transdermal patch or in a pill, hydralazine, nitroprusside, which is an IV drug only, but if you're in severe congestive heart failure, you'll be in a hospital, that might be required. Okay, so any vasodilator will also help. Okay, I hope that helps. Okay, so this slide looks busy, but again, we'll just reinforce the same idea. And really, the benefit of understanding this is that you don't have to memorize, and then the drugs will make more sense. Okay, so let's start off with stage A, risk factors. So let's give someone all the risk factors. So you got a 65-year-old person who has long-standing hypertension, already has a diagnosis of angina, coronary artery disease, had a valve repair 5 years ago, is quite obese, was diagnosed with diabetes that has led to renal failure. Oh, and also is a smoker. So multiple risk factors. Oh, and by the way, has a family history of heart disease. So what's going to happen? So left ventricular hypertrophy and diastolic dysfunction. Why does that happen? Well, that's mainly from the hypertension. So hypertension just means that your poor left ventricle is going to have to pump against a very high blood pressure to get the blood out of the left ventricle. And the left ventricle thickens. And the muscle, the myocardium, gets thicker and thicker and thicker. So either the muscle is going to get so thick that it can't fill with blood in the left ventricle, and that's diastolic dysfunction, because it just can't fill. Or systolic dysfunction, which is the usual way we think of heart failure, is that the left ventricle muscle is weak because there's been damage to it. And that's usually because they've had a heart attack. Okay? So there's diastolic dysfunction, which means the muscle is just so thick from chronic hypertension that there's just nowhere for the blood to go into the left ventricle. Systolic dysfunction means I just can't contract hard anymore because I've been damaged over the years from a heart attack. Okay? So as we progress around this, the circle there, the body is going to sense if there's any reduced cardiac output for any reason. And it's going to activate its systems, such as the sympathetic system and the RAS system, to make sure it maintains blood pressure. But that's going to have harmful effects, right? Because those two systems are going to make the heart work harder, and they're going to elevate blood pressure as well. The risk factors are going to continue to cause atherosclerosis in all the arteries, but we're talking about the coronary arteries here. So there's going to be more plaque formation. There's going to be more angina, cardiac ischemia, potentially more heart attacks, which is going to weaken the pumping of the left ventricle even more, which is also going to activate the sympathetic system and the RAS system even more because there's less cardiac output. So now we're at the top here, mechanical and neurohumoral mechanisms. So mechanical mechanisms is referring to the fact that the heart can't pump enough. It's weak, so reduced cardiac output. The neurohumoral mechanisms are the sympathetic system, that's the neuro, forcing the blood pressure to stay high, forcing the heart to beat hard. And the humoral is the renin-angiotensin system that's being activated. And again, raising blood pressure and cardiac remodeling. So all these things are happening. More ventricular dysfunction. Now arrhythmias are coming in because the heart's being stimulated so much by the sympathetic system. And if it's a deadly rhythm, then you can actually just have sudden death. And people with congestive heart failure, that's how they suddenly just drop on the street. They have a malignant arrhythmia that just kills them. Okay, so how do you have a sudden cardiac death? It's either you've had a massive heart attack and your pump has completely failed within hours. That's less common. The more common way is that you've had an electrical disturbance because of either a heart attack or a congestive heart failure, and the electrical disturbance has led to sudden cardiac death. Okay, so as we go around the circle here, there's been structural damage, meaning there's been heart attacks, and there's more and more remodeling taking place of the heart. So it's becoming enlarged, it's becoming thickened. There's scars on it from previous heart attacks. And now you're in full-blown heart failure, right? And as the heart failure progresses, those systems the sympathetic and the RAS system are constantly being activated. The heart's having to work harder and harder to maintain blood pressure. And finally, there's pump failure and death. So there's cardiac arrest and death. So it's a bit of a cycle where you go from having risk factors. You don't have to have risk factors sometimes, by the way. So typically you have risk factors leading to atherosclerosis, leading to heart attacks, leading to now heart failure because the heart pump, the heart muscle has been damaged. And then you have some degree of heart failure, and then the sympathetic system and the RAS system is kicked in to constantly stimulate the heart, which is a bit of a vicious circle. And that's where we try to introduce medications to try and break that cycle of overstimulation from those systems to the heart. I hope that makes some sense. Okay, so digoxin. So it's the only cardiac glycoside that's available. And digoxin has been used for many, many years. It was felt, not so much anymore, but it was felt to be a positive inotrope. It would increase contractility. And I think for exam purposes, you should probably still think that it increases contractility. So what were the indications? Well, decreased cardiac output, usually in the setting of heart failure, right? The other thing about digoxin is that, yes, in theory, it's a positive inotrope, but it's actually a negative dromotrope and a negative chronotrope. So it slows down the electricity in the heart, and it slows down conduction, the dromotrope part, and it slows down the heart rate, the chronotrope. So we can use it for fast arrhythmias. And a common one where it's used often is atrial fibrillation. We can use digoxin on a daily basis to stop someone's atrial fibrillation from going too fast because it slows the rate down. We have other drugs to do that, but sometimes we will use digoxin. So how does it work? So it inhibits a sodium-potassium pump. And by doing so, it leads to a more forceful contraction in the myocardial, in the muscle of the heart. Okay. Now remember, it has negative heart rate effect, so it slows down heart rate. So let's look at the side effects. So we're not going to use it in any kind of a heart block because it's going to make the heart go even slower. Okay. The next two side effects are probably, the next side effect, malaise. You should know that term. So malaise is just a general feeling of being unwell. You just feel lousy. You're a bit nauseated. You're dizzy. You don't want to eat. You just feel lousy. That's malaise. And that's one of the most common side effects of digoxin, especially when it becomes toxic, at a toxic level. That's another thing about digoxin, is that we have to check digoxin levels every once in a while to avoid getting dig toxic. And malaise and gastrointestinal upset is one of the most common initial effects of digoxin toxicity. As you become more toxic, you can get halos around in your vision. Okay, so you can start to see halos. And then as you get more toxic, you start to get into slow ventricular rhythms. So it's blocking the heart rate even more, and you'll go into more and more of a heart block. So say, for example, initially it gave you a first-degree heart block. It will give you a third-degree heart block if you become more and more toxic on digoxin. And that's partly why we don't use it as much anymore, because we have to constantly check levels. And then it's not uncommon to have sinus bradycardia when you're on digoxin. I almost would say it's not really an adverse effect. It's just an effect of the drug itself, sinus bradycardia. Ventricular dysrhythmias would be definitely an adverse effect. Okay, so contraindications. So any heart block, you wouldn't add digoxin. Definitely if you had ventricular arrhythmias, you already have some kind of block, so because now the ventricles are beating on their own, so we wouldn't use digoxin there. Definitely caution in older people, because digoxin is excreted by the kidneys. So any degree of renal failure, digoxin has to be dosed accordingly. So the dose has to be reduced. So in older people, they can get dig toxic very easily. In older people, if they get dehydrated, they're not maintaining their fluids, their kidneys don't filter as much, and they become dig toxic. And they get all those nasty side effects of AV block, malaise, ventricular arrhythmias. So you have to be really careful with renal failure and old people. Okay. So in terms of nursing responsibilities, so digoxin, so just remember this, digoxin is often used in heart failure. Diuretics are often used in heart failure. What do diuretics do? They can drain you of your potassium. low potassium and digoxin do not get along. It makes digoxin's effects much more powerful. So it may not make the digoxin at a higher level in your bloodstream, but it makes the digoxin effects super powerful. So if you see an electrolyte that you have to choose, and it says hypokalemia in the setting of someone taking digoxin, that will definitely be the answer. Okay? So we avoid hypokalemia if someone is on digoxin. Now, definitely daily weights, vital signs, ins and outs, fluid restrictions, that's because of the congestive heart failure that the digoxin is being used for, right? We will check electrolyte levels because of the hypokalemia, especially if they're on a diuretic. So diuretics and digoxin, they don't get along because the diuretics cause hypokalemia. Okay, so remember that. There is an antidote for digoxin called Digibind. So if someone is very dig toxic and they have an extremely slow heart rate, say a heart rate of 30, or some kind of concerning ventricular arrhythmia because of the digoxin, we can use Digibind, which is an antibody that binds to the digoxin. Okay, therapeutic levels, good idea to remember them for digoxin. They do sometimes get asked, so 0.5 to 2 is the therapeutic level for digoxin. Okay, remember, hypokalemia and digoxin don't get along. Okay, so milrinone. So milrinone is a phosphodiesterase inhibitor, and it's used for severe advanced heart failure. Okay, so this is not a common drug that we would use. So you know, when we think of all those inotropes, someone in the ICU, milrinone could be used for congestive heart failure. Dopamine could be used to try and increase the contractility of the heart. So milrinone just happens to be in the phosphodiesterase inhibitor group, and it increases contractility to try and increase cardiac output to help the heart pump the blood forward into the aorta. But by stimulating the heart, you're always going to put the heart at risk for arrhythmias because you're stimulating it. You're telling the heart to beat harder, right? So it's a bit of a double-edged sword by forcing the heart to beat harder, but also you might put the heart into a rhythm that you don't want. Okay. So now, if you have some kind of severe valve blockage in the heart, such as aortic stenosis, well, you can make the heart beat as hard as you want if it's blocked. If the aortic valve is blocked, well, that needs surgery. You can't force something against a severe blockage. It's not going to help, right? So remember that it can cause arrhythmias, and remember that it's for advanced heart failure. It's only given IV. Whenever we're using anything to help with cardiac output, we have to remember that it's important to make sure that there's enough fluid to pump out. So if someone, say, for example, is severely dehydrated or has lost blood and their blood pressure is very low, well, we have to replace the volume of the fluid or the blood before we can help with the pumping. Because just pumping the heart without the appropriate amount of fluid isn't going to help cardiac output because the fluid isn't there to begin with. Okay, so correcting hypovolemia is important. So this is administered IV. Very limited use for 2 days. These people are typically in the ICU, continuous ECG monitoring, and vital signs. Okay, so I don't have too much to add to ginger. It's always a good idea to check with, check the interactions. I know there's interactions with blood thinners and ginger. So it's always a good idea. I know we did that in a much earlier module, actually in Farm 1. But it's not a bad idea to just remind yourself which herbal remedies need to be avoided with blood thinners, which herbal remedies should be avoided with depression, which ones should be avoided with cardiac medication. So anyways, that's just a reminder there. So antiarrhythmic drugs, some of which you'll already recognize, are drugs that are used to try and control arrhythmias or dysrhythmias. So arrhythmia or dysrhythmia is really the same term. So say we have a rhythm that's going too fast. Well, we can use an antiarrhythmic to try and slow it down. Or say we have a rhythm that, if left, is potentially dangerous, can lead to a worse rhythm and then death. So we'll try and get someone out of that rhythm. So it can be used to control a fast rhythm. It can be used to alter the rhythm that someone's in back to a normal rhythm. And sometimes antiarrhythmics don't necessarily control the rhythm, and we have to use cardioversion, electricity, or defibrillation, still electricity. Okay, so you'll see as we go along that you'll recognize some of them, and often we sometimes try not to use them because antiarrhythmics have some what are called pro-arrhythmic effects, meaning yes, they may control the rhythm the way you were hoping, but sometimes they can make the rhythm worse. So they're not always as specific to controlling the rhythm that we would like. Okay, I hope that makes a bit of sense. Anyways, it'll make a bit of sense when we get into it a bit. So this slide is just showing a typical action potential, where you have the resting potential at around minus 90, and then there's a stimulus. So this can be a nerve cell, this could be a muscle cell in the heart. There's a stimulus that sodium rushes in to the cell. Calcium is now starting to rush in phase 2. Potassium is starting to leave the cell. And then the cell repolarizes again back to its resting potential. Okay, and you'll see on the next slide that different antiarrhythmics address different parts of the action potential to try and stop the arrhythmia from happening. Okay. So here's another action potential, and what it's showing you is just where these classes of antiarrhythmics are working. So we have the action potential that goes up. Sodium is rushing in. That's depolarization, where sodium and calcium channels are open. And then there's a steady state at the top because potassium is starting to leak out. And then you have a gradual decline back to its negative resting state called repolarization. And different drugs will block different channels. And if you block the channel, basically what you're doing is you're trying to stop the arrhythmia that we're seeing in a particular patient. Okay, so it's not like we use these drugs on patients that don't have an arrhythmia. Well, in actual fact, we do use some of these drugs, as you'll see, for other conditions. So, but in general, what you want to do is antiarrhythmics impact different parts of the action potential to try and break the rhythm or alter the rhythm that the patient is in, the dysrhythmia. So class 1 antiarrhythmics, they're sodium channel blockers. They stop sodium from rushing in. And a perfect example of that is procainamide. Okay? Class 2, you've already seen them. Beta blockers are class 2. Class 3 are potassium channel blockers. Amiodarone is the prototype in that group. And class 4, calcium channel blockers, such as verapamil or cardiazam. And you can say, well, what are blood pressure pills doing in antiarrhythmic talk? Well, beta blockers, which are class 2, and calcium channel blockers, which are class 4, remember, they have the ability to slow rhythms down. They inhibit the conduction system, so that we can use, so they're negative chronotropes. So because of that, they make the antiarrhythmic group. Okay, so there's some you haven't heard of, such as procainamide and amiodarone, but there's 2 groups that you've already heard of, the beta blockers and the calcium channel blockers. And basically, they impact different parts of the action potential. The sodium channel blockers block the initial part, where sodium is rushing in. Calcium channel blockers block the calcium from rushing in at the top. And potassium channel blockers, such as amiodarone, block at the repolarization stage. Okay, and of course there's class 2, the beta blockers. So I don't think you need to remember everything about the action potential, but just know that there's 4 classes. Here are the 4 classes. Know the prototypes in the class. Okay, and that goes for all beta blockers. They'd all be class 2, and the calcium channel blockers that impact the heart, such as verapamil and diltiazem, are antiarrhythmics as well. Okay, so we've seen that antiarrhythmics are broken up into 4 classes. Okay, and 2 of them come from other parts of this module, right? The calcium channel blockers, the beta blockers, and then you have sodium channel blockers and potassium channel blockers. So procainamide, I don't think it's important to know that within each class there's A's, B's, and C's. No, I think if you just understand the drug and that it's an antiarrhythmic and that it's used for certain conditions, I think you're in good shape. So procainamide is a very useful antiarrhythmic, and that's really all that we use it for, as an antiarrhythmic. Unlike other drugs that we've spoken about, such as beta blockers, calcium channel blockers, we use them for an assortment of conditions, right? So this particular group, which has procainamide as the prototype, is really just for arrhythmias. So what we want to do is we want to convert an arrhythmia back to normal sinus rhythm, the normal heart rate, or the normal rhythm of the heart. So under these indications, you'll see that there's some pretty dangerous rhythms, and there's some somewhat harmless rhythms. Some come from the ventricles, some come from the atria. So ventricular tachycardia is typically quite a dangerous rhythm. It's a fast rhythm that's coming from the ventricles that doesn't have any control from the normal rhythm of the heart. So people in ventricular tachycardia often either go into congestive heart failure, or they finally have cardiac arrest. So it's a rhythm that we don't like to leave anybody in. Supraventricular tachycardias. So supraventricular means above the ventricle. So what's above the ventricle? The atria. So some atrial tachycardias, we also use procainamide. And that would be atrial fibrillation, another one called atrial flutter. There's actually a rhythm called SVT, supraventricular tachycardia, that we can use procainamide for. But I think as long as you remember that it's used for atrial tachycardias, ventricular tachycardias, and really what you're doing is you're trying to cardiovert them back to a normal rhythm with a chemical. So the whole process is called chemical cardioversion, right? So whatever antiarrhythmic you're using, if the plan is to convert someone back to a normal rhythm, well, you're using a chemical to do it, so you're chemically cardioverting them, compared to using electricity with a defibrillator, where you're electrically cardioverting them. Okay. So procainamide blocks sodium channel ion channel. Sorry, let's try that again. It blocks sodium ion channels in the myocardial cells. So it's that first part that shoots right up, the influx of sodium in the action potential. And that reduces the irritability of the heart, because you're blocking the action potentials from being highly irritable. So that can stop certain rhythms, which is good. Okay, so the adverse effects. So if a nurse is hanging some procainamide, there's two things that we watch out for. One, while the procainamide is dripping in, it can cause hypotension. And secondly, while the procainamide is dripping in, it can cause a widening of the QRS. The QRS is that segment of the ECG that is ventricular depolarization. And because procainamide slows down action potentials, stops the influx of sodium, it can widen the QRS, make it slower. So when you make an electrical conduction slower on an ECG, it actually widens it out over time. So, but we don't like widened QRSs, and we don't like hypotension. So those are reasons to hold the procainamide and maybe restart it at a lower rate, at a slower rate, or even just to stop it. Okay, so those are the two effects that we really watch out for. Okay, so contraindications. Well, definitely hypotension, because it's going to cause more hypotension. A second or third degree heart block. Well, procainamide's already going to slow down the heart rate, so we don't use antiarrhythmics typically in very slow heart rates. Most of them are just going to slow it down even further. So most antiarrhythmics are used for fast heart rates, for tachydysrhythmias. Okay? So if you have a heart block, well, that's going to end up being a slow bradycardic rhythm. We certainly wouldn't use an antiarrhythmic for that. We'd be looking more at a pacemaker to increase their heart rate, or maybe even possibly some atropine to increase the heart rate. Okay. In terms of so while this procainamide is hanging, there will be blood pressure cuff going off every 10 or 15 minutes to watch out for for hypotension, and there'll be a constant ECG monitor to watch out for a widening QRS. Okay. So that is procainamide. Okay, and let's go on to the next antiarrhythmic. So amiodarone. Again, this particular drug we only use for arrhythmias. And the reason I'm kind of repeating that is because beta blockers, calcium channel blockers, are used for other conditions, right? Angina, hypertension. Beta blockers can be used in moderate to severe congestive heart failure. So, but amiodarone, the other one we just spoke about, procainamide, is really they're really just antiarrhythmics. By the way, before we start amiodarone, in terms of procainamide, procainamide really is a hospital drug, an IV drug. It used to come in tablets years ago, but that has since stopped, and it's become only an IV drug. Okay, amiodarone is an intravenous drug, and you can also go home on it. So it comes in an oral form. So the idea, again, is to get you out of a rhythm and get you back to a normal sinus rhythm. And you can see a lot of these rhythms are dangerous rhythms. Ventricular tachycardia, ventricular fibrillation. Ventricular fibrillation really means that there's really no contractions of the heart. The heart is just contracting like a bag of worms. There's no coordinated contraction. And it can be used for certain atrial arrhythmias that obviously aren't as dangerous. So ventricular arrhythmias tend to be much more dangerous. Atrial arrhythmias tend to be less dangerous. Okay, so blocks potassium ion channels. Okay, so again, it slows down these rapid rhythms by slowing down the action potential. Okay, and this one is by blocking potassium. So as a case, someone comes in and they've come in because they can feel their heart racing, they're short of breath, they're sweaty, they feel weak. They come right back into the emergency room. We put them on the monitor. We can see that their heart is racing at 200 beats per minute. They have ventricular tachycardia, but their vital signs are still stable for now. So we have the option of trying to reverse this arrhythmia with a chemical such as amiodarone or procainamide, or we have the option of just using electricity in the form of electrical cardioversion. Okay, so there's always options. So what are the adverse effects of amiodarone? So you can get some visual changes with amiodarone. Okay, that one isn't the most serious for sure. It can definitely drop your blood pressure when being given intravenously. Okay. If you've ever seen someone on the street where they have a really kind of a bluish look to them, a blue nose, that's often from amiodarone. But the next two ones are common. Hypothyroidism. So we often check thyroid levels if you are on amiodarone at home, that you're taking it to stay out of a rhythm, a dangerous rhythm. So you'll have your TSH checked. And the other one, which is the most serious of any of these adverse effects, is amiodarone can cause scarring of the lungs. The mechanism isn't totally understood, but the drug itself leads to pulmonary fibrosis and scarring, and it's irreversible. So when someone is going on to amiodarone, they are given advice, and they are given, a warning. This drug can cause pulmonary fibrosis. So you need to let us know if you're getting short of breath, because that drug, it would have to be stopped, but it's not reversible, at least the extent that they've already acquired it. So contraindications, so bradycardia, for sure. Again, most of these antiarrhythmics are to slow down or to alter fast rhythms. So for sure, bradycardia, we wouldn't want to give an antiarrhythmic. All these other ones, sick sinus syndrome, severe sinus node dysfunction, 3rd degree block, those are all different forms of saying you don't have a good regular rhythm, and it's likely slow. So if your sinus node isn't working, you likely aren't producing a regular normal sinus rhythm, so you likely have a very slow pulse, such as in 3rd degree block. Okay, so I don't think memorizing all of the adverse or the contraindications to amiodarone is the way to go. I think just understanding that it's an antiarrhythmic, that there's some adverse effects that are important to remember, and that it's given IV at the hospital to reverse some of these more dangerous rhythms. And people often are on amiodarone at home to stop them from going into arrhythmias as well. Okay, so this next one, adenosine, is a really interesting drug. We've probably had it out for at least, probably 15, 20 years maybe. And this drug is really only for one rhythm. And it's often in young people, this rhythm, supraventricular tachycardia. So what happens is a certain part in the lower atrium, or in your AV node, the electricity gets caught in a circular fashion, round and round and round, and it can't break it. It just can't. It can't stop. It's stuck in this circular fashion, so it doesn't conduct normally from the SA node to the AV node and then to the ventricles. So because of this circular electrical circuit that's stuck, it needs to be broken. It needs to be stopped so that the sinus rhythm can then restart. And adenosine is a medication that blocks the AV node. It just temporarily turns it off. Okay, so it's almost like it's a resetting of the electrical system of the heart, because everything just stops. And you'll see that on the monitor when you give adenosine to someone, is that all electrical activity stops for about 5 to 8 seconds. So we'll talk about that in a minute, because it gives particular side effects, or it gives particular effects to the patient. So someone in supraventricular tachycardia is often someone who's on the young side. They're in their 20s or 30s or 40s, and they come in with a very rapid heart rate. And we can see on the ECG that it's called an SVT, supraventricular tachycardia. And we talk to them about the different options that we can do, and adenosine often comes up as an option. So this particular drug needs an IV that is on the larger side, and typically at the elbow at a minimum. Okay, not a little IV in the hand, but typically a larger IV at the elbow, and you'll at one of the veins in the elbow. So and the reason for that is this medication is extremely short acting. It lasts for about 10 seconds. So when we drop the medication, we have to be as close as possible to the central venous system. So a little IV in the hand won't do it, because you have to get the whole medication in as a bolus. So we drop the medication, and we're going to push the medication in very, very fast, followed by a full flush with a normal saline syringe. Okay, so we're really just pushing this whole medication in as one bolus. Okay, so that chemical completely blocks the AV node. So basically it turns off all conduction temporarily for about 5 to 8 seconds. And on the monitor, we can see that there's actually no activity past the AV node. There's no ventricular contractions. The heart is not beating at the ventricles. Okay, so we have to tell people that for 5 seconds it's going to feel like you're dying. You're going to have this feeling that you're fading away and dying, but we'll be right here. We'll get you through that 5 seconds. Okay, people often get facial flushing with it, some shortness of breath as they feel their heart is stopping, and it is. So it's not just a feeling, it is stopping. And then 5 seconds later, after the reset, the sinus node turns back on and they go back into a sinus rhythm. And it typically works very well. The hardest part of the whole thing is really coaching the patient through it. Okay, you really have to warn them. Someone who hasn't been warned of this feeling that they're going to get typically never wants to receive adenosine again. Okay, so contraindications, yeah, hypertension, but remember this only lasts 5 to 8 seconds. Heart block, we would never use adenosine in heart block. Adenosine is used in very fast rhythms called supraventricular tachycardia, so we wouldn't use it in heart block. And we typically wouldn't use it in someone with angina. Now saying that, if someone's going at a heart rate of 180 or 200, if their heart's beating that fast because of SVT, and they have angina, we want to get them out of this rhythm because the heart is working so hard, right? So anyways, understand the concept of the larger IV, the more proximal IV, typically at the antecubital fossa, bolusing the drug very quickly, having an IV normal saline syringe push right after, and then the coaching of the patient about how they're going to feel. Okay, so the patient counseling, very important. Antecubital fossa or higher, IV push typically lasts for about 10 seconds, and then it wears off and sinus rhythm starts to kick in again. I've never seen sinus rhythm not restart. Okay, because the sinus rhythm, it's an automated pacemaker of the body. It's going to turn back on. So it's not like we give this drug and there's a high risk of the heart just not restarting. That doesn't happen with this drug.